Ken, you're on mute.
Thank you. Good afternoon and welcome to our monthly fatherhood webinar series. We have an exciting one for you this afternoon, which is demonstrated by the number of you who have registered. And so we hope that we can really get through a lot of good information today. We have an exciting presenter for us today, but before we do that, we want to go through a couple of housekeeping things. So we're going to talk about grief, loss, and depression because of infant mortality, and what do we say and do for dads. Our logistics, there are two ways to listen, and these are things that we've addressed in the past. You can do it through your computer speakers, through telephone, but please don't use both at the same time as you will experience a lot of feedback. Please add your questions and comments in the chat or in the QA if you can do that, and we will get to as many of those as we possibly can, specifically towards the end of the presentation. Just a little bit of information about National Healthy Start Association. So we are a membership organization. So if you're a part of one of the federally funded National Healthy Start sites, you are by default almost a member of the association. And as part of that, there are some things that we make available to you. First of all, that is advocacy around Healthy Start programs, so that we're out there and you're out there with us talking about this very important work. We provide training, technical, and capacity building sessions and workshops for you. And so if you have any specific needs, please make sure you reach out to any of us in the National Healthy Start office, and we will respond to those inquiries. Third, we provide coaching and mentoring. So we have many experienced sites and project directors and managers and fatherhood practitioners who have been at this work for some period of time. And so we want to make those persons available to you if you're new coming on, or if there are some things that they can help with. And then finally, we look at developing and disseminating resources and tools. And so there are some things that are in the works right now: intake tool and a needs assessment for fatherhood. So those things should be released towards the end of the year for you, as well as some other resources and tools we have available within our library. So we are happy to make those things available to you. So don't feel like you have to start from scratch because you're a part of a membership organization. Please make sure you reach out to us so that we can help in as many ways as we possibly can. And so I think that takes care of all of our highlighted background and those things that we needed to address beforehand. And now we will introduce our speaker and turn it over to her in just a second. Dr. Angela Hill. She is a professor and associate dean of clinical practice at USF Tanges College of Pharmacy in Tampa, Florida. She joined the college in 2011 as the founding chair of the Department of Pharmacology and Clinical Research. Dr. Hill has worked and consulted for community pharmacy practices, outpatient substance abuse treatment programs, and carved out specialty areas of practice to include, but not to be limited to, geriatrics, psychiatry, neurology, alternate medicine, and substance abuse. Dr. Hill received her doctorate of pharmacy from FAMU, or as we dearly call it, FAMU, Florida A&M University. She received postgraduate training in neurosciences and holds a certificate in medication management. She is a licensed pharmacist in the state of Florida. So without further ado, Dr. Hill, we're going to turn it over to you.
Well, good afternoon, everyone, and it's a pleasure to be here and have this opportunity to talk with you today about grief and loss and depression, and partially because of infant mortality, but just in general. And one of the things or the reasons that I'm most excited is because we get a chance to kind of put the spotlight on the men in our life, or the fathers, and certainly give them some of our attention, because oftentimes they are forgotten. So I like to actually start these kind of talks with a story and make it relatable if I can. And I was thinking, as I was preparing for this talk, I was thinking about a sermon that my pastor gave this summer, and he's in the well, my upper left of the slide, and that's he and his family as of 2000, we'll say 2012. And you see four of them. And what he did is just really talk about the importance of family. And this was the start of a series of sermons relating to family and family health. And what he and his wife did was actually kind of like this table talk approach, a round table discussion about their journey together in Christ, and in between how their family grew. And now they actually have 5 children, but between children, you notice you have 2 girls and then there's 2 boys. And then there's a younger daughter now. But between the 2 girls and the 2 boys, they had collectively about 3 miscarriages. And so they were very open and sharing, and her sharing was somewhat different than his sharing. And so this summer I kept saying, wow, it's interesting. I would have never thought that they had experienced miscarriages, because all we ever saw were, the now 5 kids. And well, I had to think about my own story. And I have a little girl who is now 6, going on 16. And one of our background stories is that she oftentimes asks, Mom, why don't I have a sibling? Because most of her friends have brothers, sisters, and the other. And I always tell her, well, my nickname should be Sarah, and you're a miracle, and you'll understand that when you get a little older. And but you have 5 angel sisters and brothers, 3 sisters and 2 brothers. And of course, this is a 6-year-old, so she's trying to figure out. But for her father and I, it's really us trying to tell her without causing her any stress that I too had collectively 3 miscarriages, totaling 5 children. And the one time that I went to the extent of getting genetic testing, it would have been a triplet set of girls, but they had a genetic anomaly, and Mother Nature, or our higher power, actually decided that he did not want me at that time to have another pregnancy. Within a year, I conceived again, and unfortunately, it was just too much of my body, and I had another miscarriage. And so then fast forward about 5 or 6 years, at the moment when I thought, well, it's just not going to happen for me, and at least I knew the piping worked. But apparently, as an academic, he wanted me to just be a play mom for everybody else's kids. He didn't have that in the cards. My husband and I had moved to Tampa. We're here 2 going on 3 years. In that 3rd year, we bought a house, and we were doing what you do. We were decorating the house and just enjoying it and all. And lo and behold, and ladies, I'm sure you can relate, time went by, didn't even think about it, and then forgot that I apparently had lost something between the house from one house to the other. I couldn't find something. And so December 18th, our beautiful daughter was born. And I said, oh, God has a sense of humor. So what I learned from that lesson is that he will certainly, give you those things that you desire, but his own timing. So I transferred to this story down at the bottom, and I don't know if you've ever seen it. It's on, I think, Netflix, but it's called Double Down with the Daracotts, I think it is, or something. And it's this family where they have, as you can tell in the picture, there are collectively 14 children. And in one of the most recent episodes, they were talking about how after the triplets, which he and the wife and the oldest daughter are holding, they had a set of twins that they miscarried. But prior to the triplets, they had lost a set of twins also. And this was a family, if you pay attention to their history, they're known for multiple pregnancies on both sides of the family. And so in the episode where she ends up having some challenges and complications, even with these triplets, he does talk a little bit about how it impacted him, but they had so many other children, they didn't have time to grieve about the loss of the one, but that they always honor the one child that was lost when they had experienced a miscarriage prior. And I was thinking about my husband and I, and how it was the same thing. Life is still going on, and you don't have time to grieve. So as I had those 3 miscarriages, I still honestly didn't think about one, stopping and grieving myself, but the one thing that I had not thought about was how it was impacting my husband. And so my pastor, opened my eyes to giving some thought to this. And so again, I want to thank Mr. Scarborough for giving me this opportunity. And I thought today we talk a little bit about infant mortality and what it looks like. We'll talk a little bit also about the symptoms that we see when people have depression, grief, and or anxiety, and what that looks like between a woman and a man, and then transition to what opportunities we have for treatment. And then I'd like to end up with you all walking away with some resources on how we can get help, because today it is just sadly impressive what the numbers are telling us. So just one statistic, for example, pre-COVID, it was noted that about 5.6 deaths per live births are, because of infant mortality in the United States. And that miscarriage actually occurs in 20% of pregnancies. Now, about 10 or 15 years ago, when I'd had my first miscarriage, the rate was down to about 15%. And now it's up as late as 2018. The numbers are about 20% of pregnancies result in miscarriage. And again, there's a lot more emphasis put on women. So this informatic kind of shows you where women, unfortunately, may not survive the pregnancy. And we do see health disparities popping up where Black women are affected more compared to white women. And we do see our American Indian and Alaskan Natives having also problems with pregnancy mortality more so than white women. And so this is an ongoing issue. What are the whys behind that? And we do have to give some attention to it, but you don't really find the numbers that really talk about the other side of this equation, because the woman didn't get pregnant by herself, but there's so much emphasis on the woman's experience, and again, the miscarriage, and nobody's really talking about what is happening to the men. Another statistic that I ran across was the infant mortality that may be related to birth defects. And what we do see is that between 2003, 2007, the numbers seem to be going down. But what we notice is a pattern with our underrepresented populations having more likelihood of birth defects. The other thing is that we notice, and we're glad that it's decreasing, but certainly that this is still an ongoing problem. And oftentimes this itself leads to a lot of challenges with the pregnancy. It leads to a lot of challenges in terms of family dynamics. There's a lot of stress associated with taking care of children with developmental disabilities and or physical challenges that lead to a lot of the problems that we're having in mental health. So we think about what's going on now. Just think of how the pandemic is impacting us. There are so many factors that are contributing to what we could describe as justifiable reasons for us to really grieve. And nobody imagined in 2019, 2018, that we would be where we were. And we thought certainly that by this time, the pandemic would be over. We would be back to a life of normalcy. And then Delta comes along, and just kind of shakes things up. So all of us have a lot of reason to be sad. And when you look at the data, since the pandemic, it's been noted that 1 out of 3 people can connect or relate to having experienced some sort of mental illness, depression, anxiety, even suicide since the start of the pandemic. And the challenge is that it's not just the pandemic. We've had issues with social justice. We've had political issues going on, natural disasters going on. I mean, it has just been a time that we will never, ever forget. And so it's been postulated that the pandemic, we hopefully will reach herd immunity maybe towards the end of the year. We hope that more people will get vaccinated, and that'll allow us to get to that point. And that maybe by next year, this time, maybe things will go away, but we might have to wear the masks a little longer. But the mental health sequelae is thought to maybe last as long as about a decade beyond this. And this has been proven with past pandemics past. But certainly what we're experiencing now is very unique. So I want to just pause, and I would ask you, if you want to use the chat to just kind of comment what life has been like you, particularly the last 18 months. Has it been, easy, breezy? How many loved ones have you lost? And what other things are you grieving over? I know this past Saturday, a cousin of mine who wasn't vaccinated, he and his wife unfortunately contracted COVID, and he didn't survive. In the meantime, he was on a ventilator for over a month. They needed to do a lung transplant, couldn't find a hospital bed. He also ended up with kidney failure, and that's actually what assisted transition. But praise God, his wife is okay. And now his wife and daughters are all vaccinated, but just think about the loss that they've experienced. I've had 3 classmates that I've lost from high school. I've had other family members, distant family, that have unfortunately passed. And I'm sure that so many of you can relate to those kind of loss. But when I think about, again, as I said in the previous slide, the people who've lost jobs, the people who are dependent on social services and things of that nature, it has just really been very, very, very stressful. And the one individual that typically takes on this is usually the male, or the male figure in our families, where, they're being strong. They're trying to keep us uplifted, keep us encouraged, or not. But a lot of them are grieving and have been impacted in so many ways by all the things that are going on. And so one of the things I just want to really emphasize is that men do grieve. And it takes a strong man to be a dad, and one to provide for his family still, emotionally, psychologically, spiritually, and in other ways. But then when we look at all of these loss, men do grieve. And so let's kind of look a little deeper at what grief really means. So when we think of grief, we know all of us, all humans can relate to the loss. It could be the loss of a pet, or it could be the loss of a human friend or loved one. But collectively, loss is a part of life. And we don't think it to be abnormal until after people are still dealing with, some of the residual parts of it 6 to 12 months after. That's when we start thinking, maybe you should be able to catch up. And there's so many different types of grief. And as life goes on, we put these different adjectives and ways to try kind of describe it. So I'm going to spend a little bit of time talking about prolonged grief and complicated grief, instead of trying to talk about all of these others, because I think that they're probably more relative to our current situation. So prolonged grief disorder could be associated with the fact that, as I mentioned, I had a high school classmate who was actually a distant cousin who passed pre-vaccine, another one who passed literally within a week of the third one. The second one had not been vaccinated. The third one had been vaccinated. But in all 3 cases, they were married, they had children, etc. And so psychologically, coming from a small North Florida town where everyone kind of knows everyone, we've been grieving. So our class is grieving over the fact that we never kind of got over our first classmate, and here now we've lost 3. But it's been estimated that globally, we're going to have, at least 16 million cases of newly bereaved people, where all of us can relate to having lost someone. And there are different characteristics, people missing their loved one. They get very preoccupied with that. And then they go through this series of symptoms. It could be anger, it could be guilt, and other things. And it lasts the 6 to 12 months, as I mentioned. And then there's the complicated type of grief, where we might use other terms like persistent complex bereavement disorder, et cetera. But there's this overlay of hopelessness and loss of function that may manifest as vocational decline or other things that we actually noted. And some of the symptoms that go along with complicated grief is this overwhelming sorrow and rumination, loss of purpose, wishing you were the one who had died instead of the person you lost, but really focusing in on the loss of that loved one. And this could be because of consecutive repetitive losses, or a mixture of different types of losses, etc. And so what we're dealing with right now in the context of the pandemic is just really making life different. And in each situation, we know that there are different types of grief, but we also know that within that, there's different stages of griefs. And so this slide just kind of outlines what the different stages are. And sometimes we get stuck on pause in, say, the anger stage and never move on to that bargaining stage, and certainly never get down to the point where we're seeking out treatment or seeking out opportunities to kind of really help feel better and kind of get through it. And so this is why we see so much complicated grief and so much prolonged grief, is that people have lost that sense of resilience, that sense of grit that allows them to just help move through these stages of grief in a healthy manner. Now, we also can't put a timestamp on how long you should cry over the loss of a husband that you had for 63 years. I mean, that's just totally impossible. But there is something about losing a child. And so certainly I could tell you stories all day about people in my family or just patients I've had where the loss of a child, it just seems unnatural for a child to go before a parent. It seems unfair to just the world in general. When children get hurt or get sick, let alone, we lose their life. And now that I have a daughter of my own, I just could not imagine what that's like. But I've grieved alongside so many people who've lost children. And so it is just really sad, but being able to work through these stages of grief is really important. How many of you saw either the movie, Why Did I Get Married, or the movie, Why Did I Get Married Too? It had Janet Jackson amongst others, but a cast of very impressive actors and actresses that Tyler Perry pulled together. Well, I wanted to point out Janet Jackson and her husband because they kind of represent what we're talking about today, and that's the loss of a child. And they experienced that in the context of their marriage. And if I'm not mistaken with the facts, apparently Janet was doing what most women do, rushing, trying to get their child ready to wherever they were going. And unfortunately, long story short, didn't put the seatbelt on or didn't check to make sure the seatbelt was on. And I think they end up in an accident and she survives and the child doesn't. So then for the next couple of years, the two of them go through these stages of grief that I just mentioned. And it was very, very different. She ends up blaming herself, and he ends up eventually voicing that he blames her. But in the meantime, in the movie, he develops a serious drinking problem, and it results really in the dissolution of their marriage. When you go on to see How Did I Get Married Too, you get to appreciate how the story of their marriage continues going on. So this slide kind of talks about some of the key differences we notice between women and men and how they grieve differently when it comes to the loss of child. And so one of the challenges particularly is when they talk about opposites attract, it could never be more true when it comes to grief and mental illness, especially because, and it's not a bad thing, but women tend to be a little bit more, it's a little bit more obvious because they're talking about it. You can tell it in their countenance, whereas men usually tend to turn inward. And then there's just this avoidance behavior a lot of time, and they go into fix-it mode is what I call it. So, and that kind of gives you this impression that they're okay when maybe or not they are okay. And oftentimes they don't necessarily get to that healthy point of communicating really where they are with the grieving process. And so the woman in the interim is really feeling resentful and trying to feel her way through and talking, oftentimes crying, and it's very visible, whereas with the men, it might appear very different. And so these behaviors are things right off the bat that make it really difficult. And so some of the strategies even that women take when dealing with grief versus a man, it's going to be different. Men might decide, I'm going to exercise more, or I'm going to just make sure that, we still have to work. And so they throw themselves in and work, and they're by themselves and maybe or may not, socialize to the same degree, where women are totally different. But we do, again, move through these stages, and hopefully in time, all will be well if we get help. And usually when it comes to grief or the loss of a child, most times people are most open and in their vulnerability to considering things like psychotherapy, and or in some extreme situations, we do have to use pharmacological therapy. So I do want to spend some time kind of talking about the role of therapies that can be used to address grief, because I think that's really important. When it comes to psychotherapy, you have all different kinds. You've got individual, cognitive, behavioral, relational, family, and then trauma-focused kinds of therapies. And just depending on, your comfortability, the expertise of the counselor, they can be extremely effective in allowing individuals to develop healthy coping strategies to move through those stages. Oftentimes, though, they may require or want you to go back through your childhood and clean up other issues that haven't been addressed. But certainly in the case of grief, it just allows you a neutral person sometimes to open up to and talk to. And so this really should be foundational therapy, if nothing else. And it doesn't have to always be with a counselor. That's where your faith-based approaches can help. That's where having mentors also can help. Having partners and things of that nature, or just friends, all of that is a form of psychotherapy. Keeping up habits, mind meditation, all of these kind of things. I said habits, but I meant hobbies. All of these kind of things can lend themselves to contributing to psychotherapy. But what happens when we don't see any kind of treatment? Well, typically, again, there might be vocational changes, or we see the emergence of depression and anxiety, sleep issues, the development of high blood pressure and other health problems, weight changes, suicide, all of these kind of things that we don't want to see. And so the sad part is that we oftentimes see, like we saw in the movie, people take on substances of abuse to fill in those empty spots. And so alcoholism, and it might even be the use of other things, but oftentimes we do see decrement in very key relationships. And so unfortunately, like in the case of Janet, that marriage didn't survive, and we do see that, as well as productivity in the workplace kind of changing. So one of the things that we've noticed is that grief and bereavement, those kind of issues typically overlap from a symptomatic standpoint with a lot of our mental health issues. So major depression, post-traumatic stress disorder, generalized anxiety, and again, our substance abuse issues. Oftentimes we'll find common themes of depression that never was addressed. And so grief just complicates it, and or vice versa. And so again, that these kind of things may warrant the need for pharmacological therapy, in addition to the psychotherapies. And so that combination oftentimes is usually going to be very valuable. But I thought it would be important to kind of show some of the key differences in terms of symptomatology that could occur when a person is dealing with grief versus depression. And a lot of it has, again, to go back to time. I talked about 6 to 12 months being crucial in terms of when we start thinking a person's been grieving a little too long. But you will have that identifiable loss, either a loss of a person, a pet, a job, or something like that. And then there being this extra focus on whatever that loss is. But what you feel is that things like self-esteem typically stay in place. Sometimes there might be guilt, especially when it comes to a child. And again, Janet Jackson's character played that out eloquently. Well, she blamed herself. The husband also was blaming her. But you'll see fluctuating symptoms that sometimes are physical. You might see this inability to enjoy things that you should. And so again, understanding why males tend to isolate, or women feel isolated, but they will seek out, again, the company of others. We'll see that. But in depression, oftentimes we do see these kind of symptoms evident themselves 2 weeks or longer. And then we start thinking, okay, there might be something going on, and it could occur independent of or in addition to people experiencing grief. And so this is really important. So one of the things that I do as a pharmacist, oftentimes when I'm evaluating, patients' regimens and appreciating their history of stuff, is I'm looking to see, and especially now in light of COVID, I'm asking, have you experienced COVID, but have you lost or had any loss of loved ones during the pandemic? Because that becomes extremely important, and it impacts their willingness to take medications, their willingness to seek medical help. And one of the disappointing things that has happened is during the pandemic, we've seen that people aren't seeking out screenings, health screenings and things as much as they used to. So I think there were about 10,000 or more less screenings for cancer than we've seen in past years. And so what we're discovering now is that when people seek out help, they're in stage 3, stage 4, where it could have been preventable or treatable at some of these early stages. And so again, as we talk about the symptoms, being able to recognize a person being depressed and or know that grief can sometimes look like depression and vice versa, really is important. And these are just examples of several of the other symptoms that we see pop up with people. But the key thing clinicians hone in on is, how long have you been feeling this way? And ultimately, what is the impact in terms of your relationships, in terms of your work life, and to what degree are you willing to either make it better, or have you gotten to a level where we need to be concerned and kind of help you or help out? So again, we always want to avoid things like suicide. So in terms of depression, the differences are also very unique in women and men. What we tend to see is, again, just like the character in the movie, more ingestion of alcohol and illicit drugs. We sometimes see people eat more, sometimes they eat less. It just depends on the person. But depending on just where they are with exercise in general, sometimes it plays out because of that. But we'll note things like irritability, short-temperedness, argumentativeness, meanness, but the risk-taking might be noticed a little bit more with men. And what we do see, unfortunately, in the context of suicide is, whereas women will attempt more, men tend to be more successful at completing a suicide. And so we always want to make sure that we're cognizant of clues that, people may have some issues. And sometimes they might just be crying out for help. And so we need to pay attention to that also. But usually with depression, sometimes there might be an impact on sleep. Either they're sleeping too much or not sleeping at all. And then we have to make sure we're ruling out other things. Now, depending on the age of the person, they may never confess to being depressed. They may say they have anxiety, but they also might be communicating things that imply they're experiencing the physical symptoms associated with depression. And I'm sure many of you have seen the commercials where they talk about depression hurts. And that's true, because a lot of people who have pain, it appears the pain is more intense. That pain might be waking them up during the night. Again, things like energy will change, interest in sex also. And these are all in that category of physical symptoms associated with depression. Women experience changes in menstrual cycle. There might be, again, dizziness, nausea, all of this could be associated, with depression. But we do relate a little bit more to the psychological side and the cognitive side. But I do think it's important that we understand the physical symptoms also can occur. And I know you keep hearing me say suicide, and it's because particularly in the last year during the pandemic, I've known 4 instances where individuals have attempted to commit suicide. And these were people that were very unassuming, who you would not even think that to be the case. And unfortunately, there were, in all cases, they were men. And as I mentioned here, we do see that there's a higher rate of suicide in men. And most times when people are already depressed, suicide is one of the things that comes up. And suicide also is, or depression is associated with things like marital status. So divorced and single men tend to be, more likely depressed. Married women are more likely to be depressed than married men. And sometimes it's because of the role expectations associated with being married, because, there's the marriage and then there's probably kids, and 90% of women now are also working outside of the home, as well as having to juggle all of the home life responsibilities. And so we do see a higher tendency of depression in that regard. But I keep harping on this because these are the kind of things that lead to suicidal tendencies also. And so we've already talked a little bit about what happens when depression isn't treated and grief isn't addressed. And I just want to tell you that this is real. We see more anxiety, we see less productivity, we see more self-abuse, and people don't even recognize it, but they're trying to replace or fill voids by using substances that oftentimes are not necessarily good for them. And so they're showing up in emergency rooms or ending up having to go into mental health facilities to try to get help. And so again, we have to pay attention to this. Sometimes though, when people are depressed, we have to do diligence and make sure there's not something else going on, like dementia, depending on the age of the patient. Sometimes there's just thyroid dysfunction or anemias, even bipolar disorder, but grief can never, ever be mistaken. And again, the loss of a child or the loss of a spouse, loss of parents, the closer individuals are to us, the more likely we need to look into this. And so just want to mention that. I thought it'd be interesting also to show you the overlap of symptoms that can occur when a patient has, or a person has bipolar disorder or major depressive disorders. It's really hard sometimes to filter, which is why making sure people get appropriate diagnostic workup is really good. And this is so important because in some cases, we have in bipolar patients, sometimes there's enough insight where they might be willing to take medications, may not be willing, might be willing to go to therapy and not. So we have to sometimes work with people in terms of what they're interested in doing or willing to do to try to resolve this. But nonetheless, we do see a lot of these overlapping symptoms between what we call major depressive disorder and bipolar patients. And so we need to be mindful of that. So if you have any questions at this point, this will be a good time to put some in the chat, and I'll ask the staff, Mr. Scarborough and others, to kind of let me know if any questions are popping up that I can address. But I want to transition with the remainder of our time talking a little bit more about treatment. Since I am a pharmacist, why don't we kind of go there so you can understand really what pharmacological treatment offers in terms of opportunities. So one of the things I'll start off with in saying is that we are truly a bag of hormones, neurotransmitters, and all kind of chemical substances that allow us to feel our emotional self. In the front of our brain, our frontal lobe is just our seat of emotions. And we go from happiness to sadness to anxiousness to depression, depending on levels of neurochemicals that actually modulate numerous body processes. And it could be heart rate, it could be our ability to think, like in the case of dopamine, it could be related to our ability to run, from a dog chasing us to being able to sleep and all. But what we do see are differences in some of these substances depending on our mood. And what we think is that in depression and in anxiety, we notice a decrease in certain neurochemicals, mainly things like serotonin and dopamine. And so when we're using medications, it's really to kind of help us equalize some of the levels of these chemicals. And again, as I mentioned, they have certain roles that they play in terms of cognition and our emotion. And so what we see, serotonin is really closely related to our sex drive, our appetite, and sometimes our aggressiveness. Norepinephrine helps with concentration, interest, our drive or motivation. And then collectively, they work on some of these things. And so this explains why some of the medications you might be using, might seem to help with depression, but also help with pain. Or they may also help with thinking or things of that nature. So this is really, really important for you to understand. The other thing I want you to get is that what is happening is that these medications might be acting on different receptors or target areas, and then that's how they produce a potential effect. Sometimes touching serotonin, and that's what 5-HT actually is an abbreviation for, may result in anxiolytic, antidepressant effects, or pain management, memory, etc. And this is what it looks like down at the neuronal level. So we have these neurons in our brain that are modulating all of those chemicals. It might be serotonin, it might be norepinephrine, it might mean, or it might be impacting different enzymes like the monoamine oxidase enzyme, and in affecting these receptors in different ways, we end up affecting those blood levels again of those neurochemicals. So that's what the drugs actually do. Now, any drug that we're using at this moment for depression, when we stay in the realm of antidepressants, none of them are addicting. But when we start adding things like Xanax and Ativan or Valium, those kind of drugs do kind of create some problems in terms of addiction. But in the meantime, keep in mind, we're always going to be thinking about non-pharmacological ways that can be used to assist pharmacological therapies. And so the psychotherapies that I talked about earlier, exercise, electroconvulsive therapy, which is extremely effective, but extremely expensive, and it does require multiple therapies, can be used in some cases. And we have things like light therapy or acupuncture. These are what we call alternative or complementary therapies, but oftentimes your insurance companies may not be willing to pay for those kind of therapies, whereas they're more willing to pay for psychotherapy and pharmacological therapy. But some of the things we can do ourselves, exercise. You go outside and get some light therapy. And, sometimes that helps. So all of these in combination really make a difference. And I just wanted to share with you that there's studies out there showing, especially, particularly in men who tend to embrace physical activity as a mechanism to channel some of their energy, that usually if they are committing 150 minutes or more per week, it actually has helped reduce symptoms of depression. So this is really helpful to know that exercise really makes a meaningful difference. Now, what I have to do, and other pharmacists, as consumers are experiencing depression, we got to make sure that there aren't factors that are influencing that. So as I mentioned, we're going to look at your thyroid, look at levels of vitamins like B12 and make sure they're okay. We're going to look and make sure that there is no grief or something that we need to address. But there's also a lot of medications that can affect the mood. And they might be used for blood pressure. They may be used for cholesterol. They might be used for acne, and even things like cannabis, which are being embraced now in the medical community. Depending on how much they're used, they actually can complicate problems. So I just wanted to show you that what we're seeing now, since the medicinalization of cannabis, and people are still using the street grade versus using the medical grade, we're still seeing anxiety and panic, some depression. They're using other drugs. We're noticing, crashes and other things that still say, again, maybe we're not getting to the core of the problem. So in a lot of cases, we have to be mindful of this. And so I may very well ask you in a patient encounter, are you using any illicit drugs? And a lot of that is because also something like cannabis can cause drug interactions with other prescription medications. So let's talk a little bit about how talented, as we kind of wind down, how talented our antidepressants are. Many of them can be used not just for depression, but for anxiety disorder. So when people have generalized anxiety disorder or PTSD, or if they have fears of spiders, fears of height, if they're obsessive compulsive, we have obsessive compulsive, we have a lot of medications that can be used to treat them across the board. So we can modify the dosing and really kill more than one bird with one stone. And that's where making sure people are appropriately evaluated becomes important. And we prefer the antidepressants over using things like Xanax and Ativan because they'll carry people during the long haul. And we just have to make sure people take them because they might take a little while to work. Usually 3 to 4 weeks, most of our antidepressants start working, but it might take 8 to 12 weeks before they start really curbing any anxiety we have. Now, we do use Xanax and Ativan to kind of bridge us until the antidepressants start working, but they're not intended to be more than a love affair. We need to really get into a deep relationship with our antidepressants. And we do this based on an individual effect, but keeping in mind these neurotransmitters that do everything, do different things, and are associated with different functions in the body, it is so important that we individualize therapy based on the person's medical problem, their ethnic background, organ function, and a whole bunch of other factors. So I know some of the concerns, particularly as we deal with male patients, they don't want their nature to be addressed or impacted by medications. And a lot of our blood pressure medications, for example, will affect erection, sex drive, and things of that nature. So we do have antidepressants that do not cause problems with sexual function or sexual drive. And so sometimes defaulting to these drugs helps. Sometimes when there's sleep disruption, if people are sleeping too little or sleeping too much, we might select an antidepressant based on that. And in some cases, we have to do what we call augment and switch our choice of therapy depending on the person. And so these are the things why you work with your clinical team. So even if you have a therapist, the therapist needs to be aware of what you're on because they may want to combine the non-pharmacological cognitive therapy with your pharmacological therapy, and or we might need to augment, but in augmenting, I have someone like me needs to make sure that the drugs don't work very similar or that they won't cancel out each other's effects or we don't have drug interactions so that we can make sure that you're going to have the best patient experience with this medication because it's a hard sell to say, I'm going to give you something that takes a month to start working. But in some cases, we have to switch between classes of drugs. And we have about 6 classes of antidepressants that we use, which gives us a lot of choice. But one of the things with depression and things like grief, they are episodic, but they can be cyclical. So depending on the number of times a person has had depression over the course of their life, that might impact how long we treat them. So that first time around, a minimum of 6 months, second time around, a minimum of 12 months. After the third episode, we want to treat for life. Now, lifetime treatment doesn't mean with pharmacological therapy. This is where the cognitive therapies really help. But we do have a cycle that we need to be mindful of. And what ends up happening is sensitivity to pain, sleep, motivation, relationships, all of this can be impacted, and it will be determined based on how we treat it or not treat it. So again, we want to avoid those consequences. So our goal when we're addressing grief or addressing depression or anxiety, it's to make sure people are adherent long enough so that they get to a stage of recovery, not just feeling better, but truly getting better and back to normal. And that does take commitment on the level of the patient in that regard. So just some things I want you to remember is that you want to talk to your pharmacist so you can appreciate how they work. We're going to be looking at drug interactions, comorbid conditions, other things, and working with the prescribers to pay attention to sleep and appetite and those kind of things. But there are a lot of other pieces that we need to take into consideration. So if you're involved with a counselor, these again are things they're going to be vested in knowing. But we want to know the symptoms, the age of the patient. Should we be adding something to the therapy, or should we switch? Is this the right therapy? Those kind of things. But I do want to end on a note of letting you know that you can help yourself. There's a lot of resources out there, some that deal with grief directly. We have a lot of organizations that offer grief counseling or that offer inpatient opportunities like Bridges to Recovery. They offer inpatient sources. There's books out there. This gentleman, Tom Golden, wrote a book on the way men heal, which focuses on the realization that men, as I said at the start of my talk, really don't get a chance to express themselves. And so we need to understand that. There's also a lot of other resources out there that are available that just address mental illness in general. So whether a person has PTSD or is dealing with suicide, there are a lot of resources out there. The National Alliance for Mental Illness has a faith net arm, but they also provide a lot of services, support groups, and things of that nature. And you can check out any of these websites as you get the slides and check them out. You can go to CVS also and actually get screenings. I'm working on a project now where we're trying to actually train community pharmacists to actually do community screening and then be a part of following patients, that are prescribed psychotropics to address their mood disorders. But there's teledoc.com and all kinds of other things out there. During the pandemic, Taraji Henson actually offered free counseling for African-American men who were dealing with depression and anxiety as a way to break the silence. Her father, whom she named her foundation after, dealt with mental illness. And so she has been very committed to this cause in terms of providing all kinds of resources. And so I would encourage you, wherever your comfort level is, that people capitalize on these. And if you're interested in more resources, reach out to me and I'll be more than willing to share. So as I close, I want to talk just a little bit, just to kind of recap what I said. Grief is natural and it affects all of us. And right now, as we're going through this pandemic, we need to know that there are different kinds of things to grieve over. And that in some cases, we don't need to try to pretend we don't need help. There is help out there. It might be pharmacotherapy, or it could be cognitive therapy, and it could simply be just supporting and listening. So whether you are a woman with a male in your life who's dealing with depression, being there and assuring them that all will be okay, helping them get resources and allowing them the freedom and the comfortability to be vulnerable and to share with you and to talk in open if they talk in the open, if they so choose. And then likewise for our men to understand, yes, we do need you to be strong and support us as well. And that we cannot allow grief and depression and anxiety to continue to destroy our personal relationships, and not resorting to substances that could actually lead to abusive opportunities. But we have to face the grief and the loss together, so that we can actually get better. So I saw this poem, which is a guide to surviving grief. And it says, cry whenever you need to, scream, shout, lay on the floor, sob in the shower, be still, run, walk, create, live your truth, share without fear, listen, release your pain, breathe, be courageous, throw away the map, wander, be real, be compassionate, read, seek friendship, be vulnerable. Don't fear being broken. And so I'd like to just say that grief affects us all. And certainly in the case of losing a child, most times depression is going to come upon us. And so we want to make sure that people know there are resources out there. If you entertain or are willing to seek out treatment, I would encourage you to definitely make sure you utilize a pharmacist. And if you can't get one, reach out to me. I'm here for you. So I'm going to stop there, Mr. Scarborough, and see if there's any questions that anybody might have. And just thank all of you for your time and attention. And again, for the opportunity to be here today.
Thank you very much, Dr. Hill. Definitely a wealth of information. I'm sure many of you have been drastically trying to grab hold to notes and take notes. And so please make sure. So we do have some questions so far. Terrence asked, do you have advice for men or dads, husbands dealing with a wife or a partner who is dealing with postpartum depression and anxiety?
Oh, yes. So with postpartum depression, it is real, and men actually experience it as well. And again, the expression of symptoms might be a little different, but the same basic rule for all of our anxiety disorders and our depressive disorders is considering cognitive therapy as well as pharmacotherapy. The one thing that we don't want to have happen, particularly in post-traumatic stress disorder, is that there be any harm to the child. And there are multiple cases out there where people didn't seek the help they needed, and unfortunately the child became the victim. So we certainly want to be proactive if we recognize any symptoms in that regard. Thanks for that question.
Sure. The next question, any idea for reaching post-loss dads with support? What Allison mentioned was they are not likely to join support groups in their community, especially not with moms who are present.
Yes. So sometimes in that case where men aren't open to support groups, if they can just be with their friends and socialize. And so I know, like, my husband loves to play dominoes. And so all of the men in the neighborhood, I mean, it's like a sorority almost. But Friday night, you can bet if it doesn't happen Friday night, it's going to happen Saturday. If it doesn't happen Saturday, it's going to happen Sundays. And some weekends it happens Friday, Saturday, and Sunday. But what I find is that male companionship allows them comfort. Now, women, we have to pay attention. If your spouse or significant other comes from a male dominant family, he needs that. That is very healthy for them. And we need to have that level of trust to allow them to have those healthy kind of relationships. They can't be up under us all the time and don't want to be up under us all the time. And it's not healthy for them to be with us all of the time. There needs to be balance. And so I do think that allowing them to find what that niche is and where they're willing is great. Sometimes we harp on wanting them to go to church, but that isn't, something that they always like either. So whatever works for them, be flexible. And I've gone to football games and things, to support the things that they like also. So I think doing that, encouraging exercise is also something else that could take place. Mm-hmm.
Thank you. Mm-hmm. Irma asked, do the stats show that bipolar has increased as well?
So yes and no. So what's happening with bipolar disorder is that a lot of people with bipolar disorder are extremely intelligent people, and they're able to function very well when they're in their manic state. And all it takes is one manic episode for you to get the diagnosis. Now, if you're depressed, everybody knows it because most times they're in the bed, not functioning, etc. But usually when they're manic, they are extremely productive. And you might notice they hadn't slept in 2 or 3 days, but they're getting so much done. But unfortunately, that's where our highest rate of suicide is, and our biggest challenge with medication adherence. They don't really want to take the medication because they feel they're okay, and because they're doing so well and can function, and they have that intellect usually in place where it becomes really kind of challenging oftentimes to convince them that they need it. But that's the group where the cognitive therapy really becomes important. But yes, the numbers are increasing, but some of it is because we're screening more. So it's just like anything else. If you look for it, you may find it, but we are becoming more astute in our diagnostic processes.
Thank you for that. Matt asked the question around depression and grief and how kind of what sorts of conversation might be helpful in getting dads and men to believe that this could be a help for them to seek out help.
Oh, yeah. So sometimes the best approach is to suggest it as family therapy, honing in on how Mr. Scarborough is dealing with it versus how Miriam might be dealing with it. You know, when we put that spotlight on them, he's probably not going to confess that, yes, I'm depressed, you know, and because we're going to be looking to Mr. Scarborough to keep us all lifted up, right? Because we have that expectation of our men to make everything okay. So he's going to do that. He's going to fix it and make it right. Now, in his quiet times, he might very well, you know, cry, but we'll never see it, kind of thing. And so sometimes saying, well, Miriam and Mr. Scarborough, why don't we as a family, you know, kind of seek out some therapy. Sometimes that allows some help. And then you can have spinoffs where it becomes individualized. And a good counselor knows how to really hone in on who has the problems and where the help is needed. But many times, particularly in the case of grief, it'll be suggested, funeral homes suggested, your primary should be suggesting grief counseling. And if you have good friends, you know, they'll be there and they'll listen, but they won't be able to be with you at home when you are accustomed, particularly to seeing a child greet you at the door, and then you go home and that child's not greeting you there. You know, they may or may not be able to help you through those kind of moments. And that's where the cognitive therapy really helps, because you got to undo patterns and rituals, you know, of having lived with people. And so that's why we like the counseling. Yes.
All right. So Tim asked, do you speak to men about how testosterone and depression? So I don't know if that's a request for your service.
No, so actually this past summer, I did some lectures looking at male menopause, post-traumatic stress disorder, and depression, but I took it from testosterone versus estrogen. You know, again, so yes, reach out to me and I'll be glad either to do it for the, you know, that's something groups tend to benefit from, just to let you understand how similar and different we are, but why it expresses itself differently too. Mm-hmm.
I think we have one more question. We're at 201. So group, if you could give us to at least 203 or 205, if that's okay. So could you speak to the organization like, I think this is Gildas Klube? Have you heard of it?
I haven't heard of that. Let me see if I can. And
their importance. So that was Bo and Strong Beginnings. Is that Latino base, Bo? You may
No, it's not. Gildas Club has different clubs around the country. So just speaking to their role in grief and grief counseling.
Okay.
Oh, I have to check on them. I maybe it's because I'm in Tampa that I haven't heard about them, but I have to check them out. Yes. Mm-hmm.
Thank you for sharing that, Bo.
Yes, yes.
People keep asking about the recording. Yes, it will be available. And Caroline, Miriam, did I miss any questions?
No, I don't think so. I think you got them all.
Okay.
All right. I just have one question. It says, how do you encourage someone to take the initial step of moving forward or beyond depression while not minimizing their experience?
Yes. So that becomes very tricky, and it really depends on what kind of relationship you have with the person. You know, if they trust you, if they're a blood relative versus a friend or a work, you know, companion, those kind of things. Because I do think that we need to know when to stay in our lane, you know, because there's some areas that we don't need to be in. But depending on your relationship with the person, sometimes talking to the wife is the best way. But I think as an employer, reminding people that you've got things like employee assistance programs, programs. If you're a supervisor in a supervisory capacity, there are some neutral things that you can do where you're speaking to the group that you supervise versus pulling out that person. But definitely when there are impacts that bring you into opportunity to have discussions, I would encourage you to do it in the context of that. So if it's in the workplace and you notice they're late at work or they're going to sleep at work, I think as a supervisor, it's fair to make sure that they're okay, not making any kind of assumptions about what's going on. And I just think as humans too, we need to read between the lines sometime. And so if you notice that people are having life situations, we need to check on them, as well as just be there for them and offer suggestions, but again, depending on your connection with that person.
Thank you. Well, I think that concludes our webinar for this afternoon. If you guys need any additional information, please make sure you reach out to us at National Healthy Start, info@nationalhealthystart.org. We'll be happy to respond. If there are some questions that we did miss somehow in the chat, we are happy to go through the chat thread and get that information to you. If you guys also need to reach Dr. Hill, we will have her email available to you as well. Just a note that I put in the chat, please make sure that either on your team or as part of your community action network that you have someone who can offer these extended services to your clients, because oftentimes they're experiencing the grief, the loss and depression with or without your knowledge. And some of that can be a barrier to your being able to provide services to them. And so please make sure that you have those persons. If anyone has been on the webinar today and you need some additional follow-up, again, please reach out either to someone who's closer to you or to our office so that we can connect you with the services. There's no reason to walk through this journey alone, because your clients and your participants need you, and they need you to be at a place where you can help them as well. And so again, thank you so much, Dr. Hill, for being willing to provide this to us this afternoon. Thank all of you who have joined us. Thank you, Caroline, and for Miriam for supporting our webinar this afternoon. Please make sure, just as a reminder, our next webinar is, I think, on November 12th. And our monthly newsletters, be sure to get your submissions in by the 5th of the month, okay? Thank you again. Good afternoon. Take care and enjoy the rest of your day and the balance of your week.
Bye-bye.